Good evening, everyone. On behalf of everyone at Eversight, I would like to thank you for joining tonight's program, Therapeutic Keratoplasty, When and How. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of your screen. We will address all questions at the end of the webinar. At this time, I would like to introduce our speaker for this evening, Dr. Vishal Janji. Dr. Janji is a professor of ophthalmology at the University of Pittsburgh School of Medicine. He is a corneal specialist and a clinician scientist by training. Dr. Janji completed his ophthalmology training from the prestigious All India Institute of Medical Sciences in New Delhi, India, and his fellowship from the Royal Victorian Eye and Ear Hospital, University of Melbourne, Australia. He worked as an associate professor in the Department of Ophthalmology and Visual Sciences at the Chinese University of Hong Kong. In 2017, Dr. Janji joined as a professor at the University of Pittsburgh School of Medicine. Dr. Janji, I'm going to turn it over to you.
I'm gonna go back. It's always good to start with the technical stuff. Thanks so much, Michelle, for that nice introduction. Can you hear me?
Yes, we can. Thank you.
Okay. All right. Okay. So my name is Vishal Janji. I work at the University of Pittsburgh, and I want to thank Eversight for organizing this webinar. This is a really nice effort that helps us teach more people than we can ever imagine working from a single center. All right, I do not have any financial disclosures that are relevant to this topic. I'm going to reduce this. Okay. So what is therapeutic keratoplasty? So by definition, it is the use of a corneal graft for terminating or improving an actively infectious corneal disease, or for repairing an anatomical defect in cornea, which is probably a fancy way to say corneal perforation. So the objectives of therapeutic keratoplasty are to resolve an infectious and inflammatory keratitis, which is refractory to conventional medical therapy. Also, an important objective is to restore the structural integrity of the eye, and we'll talk more about that in a bit. Major indication for a therapeutic keratoplasty is corneal perforation, and again, we will talk more about that in other slides, how to avoid reaching that time point. And corneal perforation, obviously, the etiology is either infectious or non-infectious. So in terms of infectious keratitis, in the developing and developed world, there are clear differences. Bacterial infections are more commonly seen in the developing world. When you see a corneal perforation, which is secondary to keratitis, you always think about Pseudomonas. Even here in the United States, most of the contact lens keratitis are caused by Pseudomonas. You can also have recalcitrant staph infections. In the developing world, you also see more fungal keratitis. Fusarium is particularly associated with corneal perforation. You can also have aspergillus. Perforation with candida, it takes some time. It's not uncommon, but it's not as common as fusarium, I would say. Herpetic eye disease, more commonly seen in the developed world compared to the developing world. That's what we used to think a few years ago, but now with increased sort of awareness about the existence of herpetic eye disease and also the availability of PCR testing, there are quite a few reports from the developing world as well. When herpetic eye disease becomes necrotizing herpetic keratitis, you can expect a perforation in these patients. And of course, don't forget acanthamoeba, especially in contact lens keratitis cases. This is a clinical picture showing melting soupy cornea, pretty thin in the center, and impending perforation in a case of severe Pseudomonas keratitis due to contact lens use. This is another patient with necrotizing herpetic keratitis. If you look carefully, it's an impending perforation, and Seidel's with pressure was positive in this patient. Sometimes ectasia, severe ectasias can cause a spontaneous corneal perforation. This is a patient who had massive keratoconus along with pellucid marginal degeneration. And as you can see, the perforation happened right at the edge of the thinning, in where you would expect the pellucid marginal degeneration to show. So I'm just going to discuss this quickly. In corneal perforation, in general, we treat the associated conditions. For small perforations, you can do bandage contact lens with corneal gluing. We'll talk about gluing in a bit again. You can also do an amniotic membrane transplant, a Tenon's patch, or a DALK. For large perforations, you do a therapeutic keratoplasty or a therapeutic sclerokeratoplasty, which is when the perforation is actually extending beyond the limbus. So this is again a very straightforward video. A patient on a slit lamp with fluorescent put in the patient's eye. This is a patient who had a corneal glue, corneal gluing done to repair a perforation. But you can see the sidal test is still positive at the edge of that glue. You can see the fluid coming out every time the patient blinks. That's another patient with herpetic stromal keratitis. This is a circular perforation about 2.5 to 3 millimeter in size. So we usually glue these patients on the slit lamp. The idea is to remove all the debris. So I want to pause the video here and just tell you what we're trying to do. So basically, after cleaning the debris, we punch out these plastic circular discs using skin biopsy punches, usually 3 millimeter in size or 4 millimeter in size. You can do more than one patch. This is a plastic patch. So the edge of the Wexel sponge is actually dipped in lignocaine gel, or you can use erythromycin ointment as well. Once that is done, the plastic disc is going to stick to the edge of the Wexel sponge. And then the other side of the disc, which is facing the eye, is dipped into a small well containing cyanoacrylate glue. And the whole complex is then put on the cornea. It sticks immediately, and you can see it looks pretty clean as opposed to that big mountain of glue that we create sometimes while we are putting glue on a corneal perforation. And as I said, you can, if there's a need, do more than one disc. This is how the perforation looked like. Again, you can see it's not a large perforation, but you can see the divot here. It's pretty sort of clear here. And that's how the leak looks like. This is how, this is right after the corneal gluing. As you can see, there is no mountain of glue. So it's actually easy to put a contact lens on this. And if you're wondering, where does this disc go? The disc actually stays on the cornea with the glue for as long as you plan to keep the glue on the patient's eye. This is another patient just showing severe ocular cicatricial pemphigoid. You can see the entropion of the upper lid, massive corneal vascularization. There's an entropion and symblepharon. This video just shows how on slit lamp you can actually see the aqueous seeping right out of that cornea. There's a tiny perforation. There you go. So what we did was, instead of putting a patch, because the perforation was really tiny, we actually used a small 27 or 30 gauge needle to, so first you dry the surface of the perforation, the epithelium. See, the speculum came out because there's hardly any space, because the epithelium is off around that perforated area. So once you have identified where the actual hole is, it's not too big. It's probably about 1 millimeter or even less than that. Once that is dried, you actually dip the tip of the needle. Just a tiny amount of glue is sufficient. And just stay there. You have to let it dry because the speculum cannot stain. So the assistant is actually holding the upper lid. Just give it a few more seconds and then you will see the surface dries up. Once that is done, the leak stops. So that's another way to sort of do corneal gluing without creating that mound of glue, which won't let your contact lens sit there and the patient stays comfortable. So that was about gluing. So when do we do a therapeutic keratoplasty? So if the ulcer is not gluable, if that's a word, which is usually more than 3 or 4 millimeters. Having said that, we have tried to glue just to tide over time. corneal perforations that are larger than 3 or 4 millimeters. It doesn't work always, but in general, the rule is if the perforation is more than 3 or 4 millimeters in size, you have to go ahead and perform a therapeutic keratoplasty. The second indication is if, when there's a limbal or involvement of sclera or limbus, even if there is no perforation, you can go ahead and do a therapeutic keratoplasty. Or if there's a large impending perforation, perhaps if you remember one of the pictures that I showed of Pseudomonas keratitis, that would be a good indication instead of waiting for the perforation to happen. So timing in therapeutic keratoplasty is really, really important. So you will have, these are three typical cases that we see in the clinic. So if you see a patient like that with limited involvement, infectious keratitis, but limited involvement away from the limbus, vessels are coming in, defect is not too large, there's hardly anything, it is okay to wait. And of course, you have to rely on your microbiology feedback, you have to rely on the antibiotic susceptibility data, and you also have to rely on how the patient feels while the patient is being treated. If your patient is getting better, of course, you're moving in the right direction. Then there are patients where you're not very sure what needs to be done. So in such patients, we follow the rules that I just mentioned. So here the hypopion is there, but limbus is still spared. You have to keep a very close watch. If this is a staph infection, when you have the antibiotic susceptibility, you can afford to wait. On the other hand, if you do not know what that is, it's been more than a week since you've been treating the patient is not getting better, it is better to go in early rather than waiting, because once this crosses the limbus, then it becomes difficult to manage. And of course, then there are patients where there is absolutely no doubt that you have to go in with a surgical intervention, massive infection, almost a corneal abscess, almost going into the sclera. So this patient would need a large graft, which would be manually dissected, and it'll have a frill of sclera as well. Hopefully, we'll have a video showing one of those. So once you've decided you're going to go ahead with therapeutic keratoplasty, very important to have a clear-cut pre-op evaluation, detailed examination on the CT-LAM. You have to measure the size of the infiltrate because that is going to determine your size of the trephine and its relationship to the limbus. So unlike optical keratoplasty, you do not have to worry too much about the centration. If your infiltrate is decentered towards the inferior limbus, it is okay to do a decentered graft rather than doing a very large graft. You also have to look for the degree of thinning and perforation. You do not want to trephine if the thinning is localized, because your suturing is going to be very challenging. And also the status of anterior chamber, whether there are any anterior synechia or not, whether the patient has got any cataract or not. We always perform, if there's no perforation, especially an ultrasound B scan of the back of the eye. If you're dealing with concomitant endophthalmitis, especially in fungal keratitis, you probably know the visual prognosis is not going to be great. So at this stage, in a patient, depending on what the status of the eye is, how much the vision is, what is the status of the other eye, what is the age of the patient, the discussion can actually go either way. So you can go ahead and do a keratoplasty along with your retina colleagues. Sometimes these patients will also benefit from a temporary K-Pro vitrectomy and then a corneal transplantation. So very important to rule out posterior segment disease. As I mentioned initially in one of the slides, it's important to look at what the etiology is in culture-proven keratitis. The antimicrobial treatment has to continue. If you do not have an etiological diagnosis, you can start the patient on broad spectrum antibiotics or combination therapy. We do use intravenous mannitol, sometimes before the surgery and sometimes during the surgery to combat the positive vitreous pressure. It helps a lot in open sky keratoplasty. In terms of anesthesia, although I did mention that we use peribulbar, but mostly in therapeutic keratoplasty, because of the infection and the associated pain, we go for general anesthesia in these patients. It helps a lot and also decreases the positive vitreous pressure. In terms of surgical technique, you got to have a good exposure. We use lid sutures sometimes. Usually a speculum is good enough. You have to avoid any external pressure on the globe so that you do not cause extrusion of the intraocular contents of the eye. We do not use the Fleringa ring anymore because the role of the ring is controversial. I do use it when I'm operating with my retina colleagues, especially if you're doing a temporary K-Pro. We take full advantage when we are doing therapeutic keratoplasty. This is a patient who had a fungal infection, which we did not know until the patient was on table. So before we embarked on this, huge surgery when he was supposed to have his graft, we did take a sample. This is braided silk suture. See how it's being passed actually through the stroma, making sure that it goes through the infiltrate so that you can get some sample. This is a very effective technique if you do not have a diagnosis. You got to make sure that that suture is not touching too many things, preferably nothing, while it's coming through the cornea. Longer the better. It always catches something. And what I do is I'm not showing that in this video. When that suture is out, it's hanging in my left hand, and I start cutting that suture in small pieces and directly plating them when the nurse is actually holding the plate. So preparation of recipient bed, very important. The goal is to excise all the necrotic or infected tissue. So do not worry about how big your graft is. Do not worry about how good looking your graft is going to look like. Remember, the goal of therapeutic keratoplasty is not visual rehabilitation. Obviously, your patient is going to hopefully see something, but that is a secondary goal. So you have to measure the involved area using calipers so that you can actually plan your therapeutic keratoplasty. So we choose a trephine which is about 1 millimeter larger than the size of the lesion. So the main reason is, one, that you want to encompass all the infection. You're trying to get clear margins. This is very important, especially if you're expecting or suspecting fungal infection. It is also important to choose a larger graft because once you excise, most of these eyes will have inflammatory markers in terms of like anterior synechiae or posterior synechiae, which makes the chamber a bit shallow. So using a larger graft is actually helpful. So always use a very, very sharp trephine and use minimum pressure on the eye. Important points. Sometimes the perforations are there and you have to use a manual trephine. We sometimes try and it's difficult to suture these perforations, but you can glue them with fibrin glue. It does help, giving you some sort of temporary sort of counter support or counter pressure actually, so that you can refine them. If that is not happening, you have to do a freehand dissection, especially if it's a large perforation involving the sclera. One of the techniques that was described by one of my mentors about 15 years ago is corneal debulking. So basically, when you can't see the anterior chamber details preoperatively, but you're sure that there are going to be a lot of adhesions, you actually don't go full thickness in your initial trephinition. You actually go partial thickness because you don't know how close the iris is to the back of the cornea, the infected cornea. So once you do the initial cut, which is about at 75% depth, you do lamellar dissection from the periphery to the center. We remove the superficial part of the corneal button, and then you inject viscoelastic. It does, improving that initial layer 50 to 75%. It improves your visualization, and you can actually gently dissect. It saves a lot of iris tissue. So once that is done, you have to enter the eye. We usually use a sharp instrument, a side port for side port entry, or you can actually do a guarded entry with interior with a surgical blade as well. So as in optical keratoplasty, we excise the diseased cornea with the right and left Castroviejo scissors. Um, always send the corneal specimen for microbiology and also for pathology. You'll be surprised how many of these so-called culture negative cases will come back from pathology rather than microbiology with fungal elements. So this is the GMS stain showing fungal elements. So once the corneal, the recipient cornea, infected cornea is off, you have to irrigate the anterior chamber very gently. The membrane of the iris is removed because most of these patients will have some sort of membranous reaction which is on the iris, on the surface of the iris. We do inject intracameral antifungals and antibiotics as well. It is good to use something which is broad spectrum. It is okay to use vancomycin. If you are suspecting fungal infections, use voriconazole. That's what we use commonly in our setting. Additional procedures. So in principle, when you're doing a therapeutic keratoplasty, at least I do a large peripheral iridectomy. Sometimes I do two, one superior and one inferior, so that there's no secondary glaucoma. Um, we try and not to touch the lens as much as possible. But yes, if you have endophthalmitis, you will have to remove the lens. And if there's an IOL, generally we end up removing the IOL as well. Donor cornea is prepared after the recipient bed preparation. You have to measure the recipient opening before donor trephination. That's pretty much clear, as we discussed. There's a discrepancy of about 1 millimeter in size between the donor and the recipient. Always use interrupted sutures in therapeutic keratoplasty. The reason being that you don't want to use continuous sutures in case there is a reinfection, and also you do anticipate a lot of inflammation in these patients, in these corneas. I've never done a therapeutic with 16 sutures, really. You always end up doing 18, 20, sometimes 24 sutures. Bites are going to be longer because of the inflammation, the vascularization. You'll be surprised that you think you did tight suturing, but sutures become loose in a couple of months in these patients sometimes. So these are just some examples of patients who had a massive tunnel infection, and then they ended up having a large graft. Also a patient here with a corneal perforation due to PUK, sterile, and ended up having a large graft. So post-op management, the most important thing is to prevent recurrence of infection. You have to continue the antimicrobial therapy. This is very important, especially if you have fungal keratitis. So you have to continue with your antifungal therapy, take measures to promote the reepithelialization of the corneal epithelium. Sometimes we do start these patients on autologous serum eye drops and preservative-free artificial tear drops. It is important to control the inflammation. Role of corticosteroids is controversial, especially in fungal keratitis. So if a patient has known fungal keratitis or suspected fungal keratitis, we do not start steroids for the first 3 to 4 weeks after the surgery. It is okay for these patients to have cyclosporin eye drops. If you can't get compounded cyclosporin eye drops, it is okay to use the commercially available 0.05% or 0.09% cyclosporin eye drops while you're waiting to start corticosteroid eye drops. The visual prognosis, as I said, is although a secondary outcome, it depends on the etiological agent, underlying corneal pathology, severity of ocular inflammation, and the size of the graft. This is a video showing a massive corneal infection. It's an old video. You can see how the whole cornea is involved. And once you take up the whole cornea, there's a membrane on the iris. The whole iris is not the whole iris. A large part of the iris is actually necrotic, and then you do a large graft, which is clearly shown as freehand dissection. This graft is not going to stay on the eye with 16 stitches. You will need at least 24 stitches for a patient like this. So I want to show you one more video with some teaching points. So this is a patient who had recurrence of fungal infection. I'm going to speed it up a little bit after the first graft. So once the first graft was done, you can see there are exudates in the anterior chamber, and we were not able to get fungus or fungal elements in second scrape. But because the first graft was due to fungal infection, it was clear that this is going to be most likely fungal infection only. So the previous sutures, this is under general anesthesia, the previous sutures were removed. We were expecting a lot of bleeding. I don't know whether you can sort of appreciate, there's a lot of NVI in the eye, on the iris actually, in addition to vessels everywhere in the anterior chamber. So entry into the anterior chamber, some viscoelastic to sort of create some space. Um, so it is easy to do a regraft in these patients. You have to remove the
Dr.
epithelium.
Janji, I don't mean to interrupt, but we can't see the video.
Oh, I'm so sorry. Maybe, you know what?
It's a black screen.
No, I have to share it again. I'm gonna stop sharing. Oh, thank you for interrupting me.
No problem.
Okay, all right, here we are.
There it is. Yep.
I'm going to restart again. But the description, this is fungal reinfection in a corneal graft. So all sutures are removed. Um, and again, as was mentioning, there's a lot of neovascularization on the iris. There's actually blood vessels sort of over the inflammatory exudate inside the anterior chamber as well. So let's speed this up a bit more. So the first step is to remove all the stitches. Once that is done, anterior chamber entry is made to create some space in the eye. So it is easy, as I was mentioning, to remove this graft because all you have to do is sort of find that plane. And once that is done, you can basically peel that graft. But you have to make sure that there's enough viscoelastic in the anterior chamber before you're doing that. And there's a lot of bleeding that you can expect. Uh, this is all viscoelastic coming back. These are Azar scissors. If you don't have Azar scissors, you can use the right and left scissors as well. So I'm using viscoelastic as well, and just to make sure that I'm not touching the iris or damaging the iris. So once that is off, you definitely need an assistant in these patients because there's going to be a lot of bleeding. So once that is done, you take a breather just to figure out what you're looking at. And there you see there's still some inflammatory membranes in the center. Um, and also you can see there's a large exudate in the center and the pupil is actually festooned. It's sort of stuck down. I want to show you this again here. So while I'm removing this membrane, I realize that that actually is the anterior capsule of the lens. And it's too late now because the initial plan was to leave the cataract inside because the patient did not have endophthalmitis. So there you go, lenticular material, a lot of bleeding, and we don't know what is going to happen. And so we finally decide that we can't leave that lens inside the eye now. So we'll have to take it out. So you do very careful and slow dissection and try and peel off whatever you can without damaging the iris tissue. And my goal here is to remove as much lens material as we can without damaging the iris. So let's speed this up a little bit more. See, it takes a lot of time to sort of remove all the membranes from the center as well as from the periphery. This is, I'm removing the ledge of the corneal tissue from the previous graft. Um, sort of waiting for the bleeding to stop as well, if I'm lucky enough. It's basically, if you can see the tiny vessels on the iris. So I'm trying to stretch the iris because, you know, the goal is now to remove that cataract. Um, so some viscodilation and sort of trying to Take the cataract out. There you go. Once that is done, um, again, some use of viscoelastic. And here I usually tell my anesthesiologist to try and give some mannitol. We are not going to put a lens inside the eye because this is massive infection. So a secondary IOL can be planned later on. Again, you can still see some residual cortical matter. I'm using a Simcoe cannula, a manual irrigation and aspiration to take out the remaining cortical matter and also viscoelastic. The capsule is still intact. So this is Simcoe cannula again, sucking out all the cortical matter. So once I'm confident that there's nothing else or very little left, which is hopefully not gonna have any impact, just checking everywhere when there's no cortical matter left. We did created an inferior PI. I'm hoping everyone can see that. I'm trying to create. Let's look at this. So I'm trying to create the angle, basically, making sure that I can break the PAS, pre-existing peripheral anterior synechiae, which is quite a difficult job in these patients. So use of viscoelastic is important to separate the iris from the periphery of the cornea. So we're still lucky if you noticed that the infection is actually still away from the limbus. He's trying to take out that tiny fibrin or fibrinous membrane from the edge of the pupil, creating space. I think we're nearly done. So all right. So let's look at this once more. So this is towards the end of the whole dissection that we did. Putting viscoelastic. Again, making sure the angle is open. Putting more viscoelastic, and after that, putting a donor cornea on top of it. This is about a 9.5 to 10 millimeter graft. So the rest of suturing is pretty straightforward. Okay. Screen share. Here we are. So going back to the presentation, can you see my screen again?
It's on the screen that says video. There you go, complications. Yes.
So let's talk a bit about complications. So there are two phases of complications seen in these patients: early phase, which has been the first 2 weeks, and the late phase. In the early phase, some of the complications are pretty similar to what you see after a routine or conventional full thickness transplant: wound gape, shallow AC, persistent inflammatory reaction. You can see pretty quick PAS coming back or posterior synechiae developing. IOP can be elevated because a lot was done during these procedures. Persistent epitheal defect, which is one of the main issues, especially if the infection has been long-standing, and that is why, as I mentioned previously, many of these patients, they benefit a lot from the use of autologous serum eye drops. But the worst of all is reinfection, especially in fungal keratitis. Late complications expected: cataract, glaucoma, infection of the graft rejection because the grafts are large. Sometimes they cross the limbus. Endothelial decompensation, never be worried about that. You can do a repeat transplant if the eye is fine. If the interior stroma is clear, you can also go ahead and do an EK later on. Graft ectasia, not seen very commonly, but if you have a large graft, that can happen inferiorly. And of course, the eye can go into phthisis. You have to be prepared. The patient has to be prepared for that. So epithelial defect, large. This is about post-op week, day 6. Still pretty big for day 6. So these patients, as I said, they benefit a lot from the usual management of apical defect, which starts with preservative-free artificial teardrops, AMT, bandage contact lens, and serum drops, and sometimes tarsorrhaphy. Peripheral anterior synechia, as I was mentioning, especially in large grafts. This is one of the reasons we use a larger graft instead of oversizing this by 0.5. We try and oversize this by 1 millimeter. In graft infiltrate, which is a reinfection, the first two patients are fungal keratitis. The third one is bacterial infection, where the graft was not large enough to encompass all the infection. And visual outcomes, as I mentioned, we can skip that, though. Causative organism is important. Susceptibility to treatment of that organism. If you are treating something that was already responding partially to your medical treatment, but you ended up doing a therapeutic transplant, the outcomes are going to be good. Severity of inflammation, as you saw in that video, a lot of bleeding happened, a lot of inflammation is expected post-operatively. Timing of the surgery, as I mentioned, if you are too late, if the infection has crossed the limbus, the prognosis is going to be guarded. Type of donor material used is not relevant here in the United States, but there are places where you won't find good quality optical corneal tissue to be used in therapeutic keratoplasty. You can also use vision grafts here. You can also use glycerine preserved corneas in the developing world. Size of the graft, as we know, larger the graft, higher the risk of failure, and underlying ocular surface disorder, which can cause persistent apical defects. And of course, they can be post-operative management of these complications. If there are too many complications in the post-operative period, the visual outcomes are not expected to be great. Outcomes, so we look at them at in two ways. Cure rate, which is eradication of disease. That's the main goal of therapeutic keratoplasty, as I've said it only five times earlier. Success rate is also defined as the clarity of the graft. So if you look at this review that was published more than 10 years ago, the cure rate for bacterial infection was actually pretty good, more than 90% for fungus. It was variable, still not too bad. Viral was good, as good as bacteria, and acanthamoeba was variable, 45 to 86%. One of the main reasons, and of course, acanthamoeba needs a separate lecture, it's such a big topic, is that the detection of disease, the organism itself is pretty late. The success rate, which is clarity of, with a clear graft, is not as encouraging as the cure rate. So most of these patients, they will end up needing a repeat optical corneal transplant at a later date. I'm just going to discuss briefly about the patch graft indication when the perforation is too small for a full-size keratoplasty and too large for gluing. Usually 5 millimeter or less. We still use skin biopsy punches in some of these patients. Most common indication, at least in our setting, is peripheral ulcerative keratitis leading to a perforation, which is about 4.5, 5 millimeter in size. And the patch grafts patients do very well, depending on the location of the perforation. If it's away from the center, you can expect good visual outcomes. If it's close to the center, sometimes folks would do a full thickness 7 millimeter graft, or you can do a 2-stage procedure where you can, in a hot eye, do a patch graft, and a few months down the line, you can do a repeat central optical keratoplasty. This is a patient with the PUK massive. You can see melting of the cornea, the periphery, and you do a crescentic shaped patch graft, which is not for visual rehabilitation clearly, but it's to save the integrity of the globe. So to conclude, therapeutic keratoplasty is the final option for management of severe uncontrolled keratitis. It has to be considered only if absolutely indicated. It is surgically different from an optical keratoplasty, and post-op care includes emphasis on systemic, I should say actually local and systemic antimicrobial therapy. So thank you very much for your attention, and I'm happy to take any questions.
As noted previously, if you do have any questions, you can type them in the Q&A panel at the bottom of your screen. And we do have a couple questions, Dr. Janji. The first one is, what do you prefer if compounded, 1% cyclosporine or less? You're on mute, Dr. Janji, I can't hear you. Let me hit you.
Here.
There we go.
Yeah, okay. So we do prefer using at least 0.5% cyclosporine eye drops. But yes, if you have a compounding pharmacy, it is okay to get up to 1%. There are studies that have been done where people have used 2% cyclosporine. But what we've seen is anything between 0.5% and 1%, or if you have, as I said, 0.5% exactly or 1% exact, you can use that while you're waiting to start these corticosteroid eye drops. An important thing to consider is if you are planning to start cyclosporin eye drops, try and start them a few weeks before your planned transplant, so that while the patient has some sort of perioperative cover using these cyclosporin eye drops. I have colleagues who would use oral steroids instead of topical steroids. A Medrol dose pack is very commonly used in the United States. I have had some good success in patients where I did not know they had fungal infections. But I've seen if your patient has a fungal infection, definitely microbiologically proven before the therapeutic transplant, I try not to give them oral steroids as well because of the fear of a flare up.
Okay, the next question is, how did you make that Crescentic patch graft?
So it can be done in two ways. And there are multiple ways that have been described actually in peer-reviewed literature. One is that you can actually use two different size large trephines. And if you do not have access to large trephines, usually manual trephines can go up to 11 or 12 millimeters, not the suction trephines. Talk to your eye bank. As eye banks usually have access to large trephines because that's what they use. You can use two different size trephines and be creative and actually create a moon-shaped graft. And do not worry if you don't want to use a trephine, or you don't have access to a trephine to get a perfect cut. You can actually do a freehand dissection as well. So you can mount the cornea onto a stand in the OR and actually do a freehand dissection to get a crescentic patch graft. But what I've seen is usually if you use two different size trephines, you should be able to get a crescent, which is sometimes larger than what you need, but it's okay to have a larger graft compared to a smaller graft.
Okay, and I think this question is based off this answer. Can you explain what this is made of and use the artificial patch and fix it by ointment? Is it customized from bandage contact lens?
I didn't get the question. What are we asking about?
It says, can you explain how it is made of and use the artificial patch and fix it by ointment? Is it customized from a bandage contact lens?
So I'm going to presume that this is a question on corneal gluing technique, the one where I showed the plastic patch. So I'm going to go ahead and describe that. Basically, the plastic patch is trephined from your plastic drape that you use on the eye during any surgery, cataract surgery. You can use, as I mentioned, a skin biopsy punch to create different size discs, plastic patches from your eye drape, from your ophthalmic drape. So once you have those, I usually create a bunch of those because it's easy to sort of lose them and they just fly away. That patch, as I said, is made from plastic. I take a Wexel sponge. At the end of the sponge, the tip of the sponge, I would put some erythromycin ointment, and then that ointment will help me to get the patch stick to the end of the Wexel sponge. I hope that makes sense. Once that is done, I will dip that plastic disc, into a well of corneal glue, and then I'll put it on the corneal perforation. So as I mentioned during that video as well, I hope I can actually show that video. Hold on, it might be easier to sort of go back and here we are. Um, let me know if my screen's not visible. So if you look at this, so once that is dried off and the mucus, the debris is off. So basically, now here, this is pretty good actually. So that's the end of the Vexel sponge. You can see the ointment sort of blob hanging here. This is the plastic disc, which has been refined using a skin biopsy punch. Um, so the ointment is helping the disc to stick to this Vexel. And the other end of the disc, the other side of the disc, I should say, has been dipped into a well of cyanoacrylate glue. So this whole thing, as I showed earlier, will go onto the cornea. Of course, that other side has got glue, which is going to stick to the cornea and seal the perforation. I
Dr.
hope that
Janji,
makes sense.
there's a question regarding the well of glue. It says, can you
Uh-huh.
explain the well of glue?
Okay, all right.
What are you
So
putting the glue into? Which cyanocrylate do you use that allows you to do this?
well, so cyanoacrylate glue is available, the commercially available Histacryl. I don't have a picture here. Um, I mean, so basically the glue is available in a tiny sort of tube. So we cut the tip of the tube and squeeze in the liquid glue in a plastic cup. So that is the well of the glue, or the well with the glue. I hope I could, I'm sorry, I'm just gonna, um, yeah, I'm not sure if I have that presentation here, but look, whoever has asked this question, please email me and I'll send you pictures of what I'm talking about. So basically what I'm trying to say here is that the glue, which is commercially available, it comes in tiny tubes. It's liquid, obviously. So you can cut that tube, squeeze in that glue, which is in liquid form, in a plastic cup. And then you can dip your disc, which is stuck to the end of a Vexel sponge, in that plastic cup and then put it on the cornea. I hope that makes sense. Please
Okay.
email me. I'll be happy to send you pictures.
Okay. Next question is, what is the role of tectonic DSEC in corneal thinning disorders?
So I honestly, I have not done tectonic DSEC. I think Dr. Elmer too had published one of the earliest case reports, if I'm not mistaken. I mean, there is, unless you have a specific kind of perforation, which is sort of, I think what Elmer had published was, he had done that more for a patient with hydrops and thinning, if I'm not mistaken. But I have not used tectonic DSEC graft for corneal thinning or perforation. I don't see a point of using a partial thickness tissue um, for a perforation, especially endothelial tissue. So if you have to do a patch graft, which is lamellar, I would do sort of I would want to put in more stroma with sutures there compared to only the endothelial tissue.
Okay, next question is, in dealing with fungal related therapeutic PK, do you find an additional benefit of having a cornea button prepared in Optisol mixed with Ampho-B?
So yeah, well, so we do not mix anything in our storage media. Um, Instead of using M4B in the storage media, I mean, of course, the next question would be, for how long are you going to put it in? And that's a whole, don't miss the AAO subspecialty day, by the way, if you want to be a part of that discussion. Um, I don't use that. I would rather use intracameral antifungals, which would be more helpful. If if my internal pharmacy is generous enough, they will send me a sort of a 1 ml syringe full of my choice of antifungal drug, so that not only will I use it intracamerally, I sometimes use it to irrigate the angle as well. So I don't waste the drug at all. But I don't use anything in the storage media because, you know, we still don't know if that's going to be useful or not, and to what extent.
Okay, and it looks like we have one last question. In case of limbal involvement, do you prefer to do 360-degree peritomy for a large corneal scleral graft?
Yes, you can that's a good question, and I think surgically that it's a very sound decision for two reasons. One, when you have limbal involvement in a large infection, you cannot tell for sure whether uh, the edge of your trephinition is encompassing all the infection or not. So there were times when you have fungal infection that would have a tiny lip of extension into the sclera in one quadrant. So you have to really either excise it manually or use a really large trephine to do a sclerokeratoplasty. The second reason is that your suturing is much better if you do a 360-degree peritomy. That's a fantastic surgical question. I did not have a video on that, but that's something that we do if the infection extends beyond the limbus, especially.
Okay, it looks like there are no more open questions. So I'm going to wrap it up. I would like to thank everyone again for joining us tonight. The webinar has been recorded and will be available on our website to view on demand. A very special thank you to Dr. Janji for serving as our speaker today and for providing us with your invaluable expertise on this subject. Have a great evening, everyone.
Thank you so much, and thank you, Everside.
Thank you.